Good morning, sir.
Morning.
Presenting the case, sir. We have a 40-year-old female patient who came with the chief complaints of intermittent hematuria with clots for last 2 years, lower urinary tract symptoms for 1 year, and left flank pain for 6 months.
Who is discussing?
Shubham from K.
Good morning, sir.
Morning. Yeah, we can finish the history and then.
Yes, sir.
Okay. Anything else? It's a painful hematuria.
Sir.
Next slide.
On elaboration of his history, patient presented with complaint of hematuria intermittently in the last 2 years, which was of fluctuating degree. The hematuria was total with passage of clots. There is complaint of increased frequency of micturition for the past 1 year. However, there is no urgency associated and no voiding difficulties were there. Urine flow is normal. Patient also has complaint of left flank pain, which was dilating and intermittent, and there is complaint of radiation of the pain to the back. No history of burning micturition, pyuria, or lituria is there. No history of any previous urinary retention. No history of fever. Bowel habits are normal. No history of weight loss or anorexia. No history of respiratory distress, bone pain, or jaundice. And the patient doesn't have any history of diabetes, hypertension, or past history of tuberculosis.
Yeah, see, in the hematuria history, if you want no questions, what should be the line? If you write in one line, there will be no questions. If I can see this, in that there is hematuria, there is intermittency, and there is clots. One or two things more are missing. Priyanku?
Sir, type of clots, sir?
Okay. Whether it is amorphous clot or it's like a thread-like, it's coming from the ureter. Okay.
As per the patient, it was elongated type of clots were there, sir.
Okay. What else is, when you describe a hematuria, it should be a total description.
Whether it is painful or painless,
Yes.
continuous or intermittent, total, or whether it is initial or terminal, or associated with whether it is associated with clots, and if clots, then the type of clots.
Yeah. What you missed is gross hematuria. What is gross? What is opposite of that?
Microscopic.
Yeah. So always understood that it is gross, but you should say the terminology.
Okay,
gross,
sir.
Painless, or in this case, is this painless or painful?
Painful, sir. There is associated history of pain.
So it is, and other thing, one is gross, other thing is total.
Yeah. But the sort of pain has been present for 6 months only, but whereas the hematuria has been for 2 years. So whether to call it painless or painful, sir, I may be confused regarding it.
See, any pain in the KUB region associated with hematuria is called painful.
Yes, sir.
It is not during the act of urination per se. If it is there, yes.
Yes.
But if the patient has flank pain and he has got, while passing urine, there is no pain, you still call it as painful hematuria.
Okay.
Now, in a particular case, like what you said, that was present some time back, and those are all individual cases, but this is how it is described.
Okay, sir.
If the patient, I would put it other way, if the patient never had pain, then it is definitely a painless hematuria. If the patient had pain yesterday and today he has painless hematuria, I mean, there is no flank pain, but then you still put it as a painful hematuria. So, what are the possibilities now? KKCC, are you there? Who is?
Yes, sir. Yes, sir.
Yeah, Shubham, what are the possibilities quickly?
Sir, it looked like, sir, some blood coming from upper tract, sir.
No, differential diagnosis.
Some maybe stone or some upper tract carcinoma, sir.
Use specific terms, maybe. I mean, malignant causes, stone
Yes, sir.
disease, then
Infective, sir.
infection, UTI basically.
Yes.
It may be pollen, but I think there is no fever, but possible. Okay, then. But this history of hematuria is from last 2 years. So anyhow, in a particular case, you can debate that this may not be the cause or either. But 2 years infection is very not. It should be a short duration, a week, a month, or something like that. 2 years is very unlikely to be UTI. Okay, then. Proceed. Don't get stuck. Hematuria is every day you see in the outpatient. Stone disease, malignancy of the upper tract. Third is you said UTI. Then
Sir.
stuck with it. That's all.
Yes, sir.
Huh? Anybody else? No other cause.
Benign causes can be also there, angiomyolipoma.
Benign cause, sir. Angiomyolipoma, vascular cause, sir. Renal vein thrombosis.
Yeah, renal vein thrombosis possible. Then angiomyolipoma if it is bleeding, yes. But 2 years anyhow, possible anyhow. Then
Can be ADPKD also.
ADPKD usually bilateral flank pain. And there is no family history. I don't know. It's not yet presented, but possible. Then congenital causes. PUJ obstruction. Then you can have lower, upper tract, but at the VUJ. Can you think of some conditions? Yeah. Some mega ureter, obstruction, ureter seal, something of that sort. So when you think, you can think anatomically as well as can it be something like a bladder tumor obstructing the VUJ, causing a flank vein? Possible. So one of the commonest causes is any gross hematuria is bladder tumor. Bladder tumor can involve the VUJ, but of course I'm telling a lower tract cause producing upper tract problem. If it becomes muscle invasive, then you have, because this is from last 2 years, it is not from 2 or 3 days. So if it is involving the VUJ, so we have told you so many conditions. So when you speak a wide range of causes, the examiner thinks that you are open-minded and you are not, because somebody will tell you in exam that this is this case, you get stuck with that. Be open. You say it can be PUJ, it can be VUJ, it can be renal benign malignant conditions, UTI, stone disease, fine. And then he says, okay, you stop. Infective, you said one is UTI, if you want to add tuberculosis. Yeah. It can be a bladder calculus with a simultaneous calculus in the upper tract, possible. So by history, you are not ruling out any condition. Everything is possible when there is hematuria, including congenital causes like PUJ obstruction. Okay. Proceed. Past history. Important is whether any surgeries has been done in this patient. It may be patient may have a history of lithuria, patient may have some this thing. If it is not there, then we think of different cause. That surgery need not be urological. It may be sometimes some gynec procedure where they have injured the ureter. So any surgery, we should be making note of it. Okay. Next. See, family is not significant. You should write in a female whether she is menstruating. Is it coming in the next slide?
In the personal history, I should have mentioned, sir.
No. Whether she is having any how many children, normal delivery, whether she is LMP. And from last 2 years, if a patient is having hematuria, she would have been treated, she would have been investigated. If the patient is able to tell you, you should tell that in the history. Because I don't think from 2 years a patient has hematuria, she will be sitting quiet. Anyhow, there is nothing significant in this history.
Yes.
Anything else in the history or is it over?
Yeah, it's no, nothing.
Treatment history missing.
Yes, sir. She had visited local physician, sir, around 6 months back, but she has only given some medications, but she didn't continue treatment later on, sir.
Yeah. Whenever there's a long history of hematuria, you can assume, see, before you ask a history, she may be having anemia, she may be having loss of weight, loss of appetite, all these things. In any long case, you should conclude the history by saying she has no bone pain, no loss of weight, loss of appetite, no cough, hemoptysis, swelling of the limbs. This is a general in all long cases because you never know which case will turn out to be malignancy. That should be the last line before you go towards examination. Okay. Yeah, Priyanku, anything? Positive is flank.
On parabdominal examination, there was some fullness in her left flank. However, no discrete lump was palpable. No renal angle tenderness was there, and no other organ anomally was present. Rest of the systems had normal findings. Our vitals were also normal.
So Shubham, we gave a big list of differentials. So what is still in, what is still out? What can be excluded?
Sir, there is lump, fullness is there. Any leg swelling, sir?
There is no lump, but he said fullness. Okay, so what is still possible? What is ruled out? I mean, clinical examination wise.
Sir, some upper tract malignancy, sir.
Okay. Can it be stone disease?
No, sir. Actually, there is a left flank fullness is there. Stone disease also, sir, with hydronephrosis. Sir.
Yeah, some possible. You cannot rule out with that. Okay.
Yes. Sir.
What you can rule out? Put it other way. ADPKD. Unlikely because it is not bilateral.
Not bilateral, yes.
Okay, then there is no tenderness. So very unlikely that there is infective cause.
Infective etiology we can rule out, yes.
Then PUJ is possible. The VUJ obstruction is possible.
Possible, sir.
Yeah, all other this thing. So only as of now, UTI and ADPKD is unlikely.
Yes, sir.
Okay, right. So anything else in the examination you want to know?
Sir, leg swelling, sir, any abdominal visible veins?
Because you said renal vein thrombosis, any abdominal vessels are prominent, of course, may or may not be, and lower limb edema. I think he has written no edema, so we'll go by that. And of course, left flank, left supraclavicular nodes, all those generalized lymphadenopathy has to be seen because you have a differential of malignancy in mind. Very unlikely that the supraclavicular lymph nodes are enlarged in urology, but you should always mention it. Okay. Yeah, I think PVPR is not yet mentioned. We'll see the next slide. If something is there. No. You should in the exam, in a major case, even though it is a hematuria, sometimes it may be a gynec malignancy. Yes. The patient may say it is hematuria, but so clinical examination, if you miss, you will be in deep trouble. If the patient refuses, no issues, you can just write it there. I wanted to do a PVPR, patient has refused.
Yes, sir.
But examination wise in a lady who has hematuria, if you miss it, it won't be appropriate. You will, in a major case, you may be in trouble. It may be purely gynec condition which can cause all this. Say, there is a CS cervix invading the bladder, VUJ, all those things. So that also to be kept in mind. So your gynec history was missing. You didn't say about LMP, whether menses are regular. What is her fertility status? All those things.
Yes.
Again, every case you should, in a lady, you should ask what is the LMP and other things. Many times, patients are found to be pregnant and you have done some urological procedures. It happens again and again because everybody thinks that is not my department. Okay. Yeah, investigations now. Again, UTI is unlikely that we thought so. But what is that, what you would have thought in a patient with such a history and that is not matching with this?
Sir, RBC is 0 to 2, sir.
See, yeah, one is anemia. So in a patient who has hematuria intermittently from last 2 years, to have a good hemoglobin, either it should be RCC because they have some erythropoietin production, or there's something which is very mild hematuria, something. Hemoglobin status is very good. The other thing is urine microscopy showing 0 to 2 WBC. It need not be that every case of gross hematuria you should have a microscopic hematuria. It is intermittent. So at the time the patient gave the urine, there may not be any RBCs. It's intermittently there is bleeding. So if a patient has a gross hematuria and on microscopy there is no RBC, it doesn't change your management. You will continue to investigate this patient as a gross hematuria. So the word gross hematuria means that you will continue to investigate. You won't stop because there is no RBCs in the microscopic examination. Okay, we will. What do you want next?
Sir, do I need to repeat the urine analysis?
No, that's what I said. If you have gross hematuria, you proceed without waiting for you don't have to prove it. That point of confirming it is only 2 microscopic examination is required in a case of microscopic hematuria. Whereas gross hematuria, you don't need RBCs.
So my point was sometimes patient will be misleading the symptoms. Sometimes they will have beetroot or dark orange also they will say hematuria. At least once I have to see it.
No, you are taking the discussion somewhere else. If it is red, you show the color red. Sometimes some people, I agree, will say that high colored urine is red, but a gross hematuria does not require urine microscopic confirmation. Now, if you are looking at nephrological causes, you want to see this, whether there is a cast, this, that, and all, you may repeat it. But if you are looking at urological perspective, you don't have to get stuck with the microscopic examination. You will proceed because I am not interested in what is the type of RBC. And you have obvious causes sitting in the kidney or something like that. I won't go by the urine analysis. No. Even if it is first episode, in a case of gross hematuria, if you are suspecting a bladder tumor, you go and have a look. Nobody is going to say you didn't have RBCs in the urine, so I'm not going to do it. That is completely out. So that's why the gross is very, very important. If it is gross, you need to fully investigate a patient. Okay, next. Yeah, what next, Shubham?
Sir, radiological investigations.
You be specific, man. I don't know. Radiology
CT.
department. Huh?
And CT urography, sir.
CCT.
Yes, sir.
Yeah, the patient would have come with a scan or something like that. No problem. Yeah, in a patient who you are suspecting something left flank pain and all that, you may directly go towards the CCT. But more often than not, we end up doing an ultrasound.
She had come with a report, sir, from the previous.
Yeah, that's what I said. We cannot say I wouldn't have done it. If the patient has come with the test, what can it? Okay, so what is the finding? No images, I believe.
Yeah, the image, she came, he had a report with her, but the image was not there. Report showed the presence of poorly defined solid appearing hypoechoic lesion, hypoechoic relative to the rest of the renal parenchyma. Lesion was occupying the upper and interpolar region of the left kidney with loss of respective calcium outline, along with perinephric extension. The kidney appeared enlarged. No obvious vascularity was seen on Doppler. Right kidney and bladder had normal findings.
So coming back to our differentials, what we said, so stone disease is out, ADPKD is out, you have PUJ is out. Of course, we have right now most likely a malignant lesion. So we didn't miss out. Of course, malignancy, we should say whether you're thinking of RCC or a urothelial carcinoma, rather than saying just malignancy. Anyway, so I think we'll go with the CCT.
This is a plain CT, sir. Right kidney appears to be normal, sir.
You see all the films rather than, see one film and comment about it. Yeah. Once you're happy seeing the images, you ask us, we'll move to the next.
Yes, sir. I've seen.
Yeah. Next.
Next. Next. Yes, sir.
No. Show the images. One more.
Sir, the right kidney, sir, appears to be normal, sir. Normal contrast uptake, no stone visible in plain film in the right kidney, sir. Shape is normal.
Once you say normal, then there is no need to say there is no stone, no PUJ, okay. No this. We understand. This right kidney is normal in size, position, axis, normal uptake, excretion of contrast.
Yes, sir.
Finish.
In left side, sir, there is a large mass involving the upper pole and interpolar region of the left kidney with no contrast uptake in the mass, and the rest of the lower kidney, lower pole is having good uptake of contrast also, sir. And there are some lymph nodes visible, sir, in the left.
What is not visible?
Lymph nodes are visible, sir. Mm-hmm. And large nodes.
Good.
And
go to other images. Contrast. Okay. Go to the plane. So which tumor does not enhance, man?
Sir, RCC has enhancement, sir. In early phase, it will enhance with 15 to 20 hospital units, sir.
No, what I'm asking, because you said this is a non-enhancing.
Yes, sir.
How will you check whether it is enhancing or not?
Sir, after giving contrast, sir, after giving contrast, we will see, sir, is there any enhancement?
How? Is it a visual appearance or what?
It will be, sir, a visible appearance, sir. It will be whitish, sir.
No, that is, suppose you are sitting in a packed system, how will you quantify the enhancement?
By Hornspiel units, sir.
Yeah, so be specific. It is not just a visual feeling of that it is enhancing. You have to go by Hounsfield unit. Now everything is defined here because in a RCC it's about 20 enhancement compared to a plain study. So in, I agree it is a less enhancing, but it is enhancing. It is inhomogeneously enhancing. If you see the images, it's, see, the renal parenchyma, normal renal parenchyma enhances by around 200 Hounsfield unit after the injection of contrast. Whereas RCC enhances about 20 Hounsfield unit post-contrast. When we say enhancement of a renal tumor, we are comparing it with the renal cyst. A renal cyst does not enhance. You give a contrast, the Hounsfield unit of that cyst wall will remain the same. So there we say that it is not enhancing. Renal cyst does not enhance. Whereas when you say a tumor is enhancing means you are comparing it with the, not with the parenchyma. Parenchymal enhancement, you can see it is severely, it looks like a bulb which is off, which is getting on. So enhancement is around 200 Hounsfield units more than the plain study. Yes, whereas tumor will enhance by 20.
From plain studies.
Whatever the baseline was, if it was some 10 or 15, you have packs in your hospital, you play around with that, you will know. You check the Hounsfield unit in a contrast study if of the renal cyst, of the renal parenchyma and the tumor before and after contrast. So some of the things you will have to do it yourself, then only you will remember. Otherwise, you will be just reading the textbooks. So here, there is inhomogeneous enhancement. I think some of the images you are seeing some enhancement.
Yes, sir.
Yeah, I think show the other films. See, if it is completely black, what do you think of? I mean, it is not enhancing at all. What are the... One is it's a simple cyst, let us say. Then anything else?
Sir, this angiomyolipoma. No, sorry, sir, that will enhance.
It will have a minus HU.
Minus, yes.
If you have to have a fat. Of course, these are angiomyolipoma. So it is a angio means it's a vascular thing. Yes, so any vascular tissues will enhance.
Cyst, sir, any abscess, sir, renal abscess?
Renal abscess is one of the differentials for RCC because the wall of the infected cyst will enhance.
Okay.
Some other benign tumors, oncocytoma, and those things are non-enhancing. Yeah. And of course, if it's an infarct, that area will not enhance at all. See, when you described, I understand you explained about lymph nodes, but you should comment about you can see in that bottom image in the middle, there is a inhomogeneous enhancement, is clear in that. Second, you should comment about the calyces. What is the margin? It has lost its reniform shape, the kidney. And you have to look into the surrounding structures, which include the adrenal gland, the spleen. How is it in relation to these organs? Are you able to identify the adrenal? Then you should comment about the renal vein. What about the arteries? There are one artery, two arteries, because you are looking from a surgical perspective, whether you can do a partial nephrectomy or not. So you should say, there is single artery, it is branching here, it is going, I may be able to clamp this and remove this, whatever. So when you are talking, you should be, I should be thinking that you are planning to do surgery, planning to do a partial or radical. In that way, you should speak. My renal vein is all right, so there is no venous involvement. You're speaking in terms of the staging directly. There is no renal involvement. There is lymph node involvement. Is there the surrounding organs? As I said, the adrenal gland, spleen. There is no other organ involvement like the liver. And so that should be your way of describing. Don't stop. Continue. Because sometimes there can be bone mets also. So you should look at all that. Take your time and continue. And you should tell about the calyces, which I think, did you comment about the calyces?
Yeah, no.
Is the calyces looking all right, or sometimes they're destructed? In a tumor, they can be infiltrated, they may be destroyed, they may be stretched. All these things you have to tell. Or you are unable to visualize the upper group of calyces is something which you have to tell.
Okay.
And the left ureter, the rest of the kidney, there's normal uptake, calyces are well seen, all those things. So what happens, sometimes you get stuck at the tumor and you forget rest of the things. So you should look at surrounding, whether there is perinephric stranding, whether there is infiltration of the fat, whether there is involvement of the colon or adrenal or spleen, because that will change your management. Most often this is the only CT we have before operating. So look at completely, and because that is how you will have to plan the surgery.
So there is a single renal vein, sir, and venous involvement is not there, sir. No thrombus, and the left kidney in the upper pole, I think the spleen is also involved, sir.
No, don't comment on the longitudinal section. You will have to look at the cut sections. Can you see the spleen there?
Yes, sir.
Why you are thinking it's involved? There's a good fat plane. See, when you have a good fat plane, there is unlikely to be any involvement. In some images, there is something called as between the liver and the kidney. Sometimes there is no space, so it looks like organ. Some terminology. There is loss of flat plane. So sometimes these organs are very close by. Unless there is some irregularity of the organ at that margin, you keep saying that the radiologist just says that there is absence of fat plane. They won't say it is involved, it is not, or it is free. But in this case, there is a good fat plane between the spleen and the, I think on the uppermost sections, the upper, Yeah, it is very close to it, but very unlikely to be. In some of the images, there is a fat plane. Okay, anyhow, there is loss of fat plane between the spleen and then what else? You commented about the renal vein. You commented about the spleen. What else? Artery. You are there?
Yes, sir. Yes, sir.
What do you want to tell in artery, man?
Single artery or some double
That's
artery.
all? Yeah, good. One is single artery. Then
And
the branching at the hilum, whether you will be able to clamp it separately so that that part of the kidney can be removed, or segmental branches.
yes, sir.
This is a CT angio type. If you see, I think you can see one vessel going directly to the tumor. So, how is the branching at the hilum? If you are able to appreciate, yes. And you said lymph nodes. So you should say what you cannot say lymph nodes and keep it blank. What is the size of it? How is it in relation to the aorta or a vena cava? Is it something you think it is infiltrating the surrounding structures? All those things. Once you say something, you cannot say, "Oh, I have made a finding." Then rest of you assume what the finding. How big are the lymph nodes? Are they what group of lymph nodes?
They are para-aortic lymph nodes, sir. And the size is not that big, sir. Small lymph node, about 1.5 to 2 centimeters.
Yeah, you say that there are several lymph nodes. The largest is 1.5 centimeters. That's how even the radiologist will report. Multiple lymph nodes in the para-aortic region, and the largest lymph node is so and so centimeters. Okay, then if you should be able to comment about adrenal gland, or you should say, I'm unable to appreciate the adrenal gland separately from the tumor.
Yes, sir. The adrenal gland left side we cannot see separately, sir.
Okay, how many percentage of human beings have no adrenal gland on one side?
I don't know.
Dr. Ganesh used to usually ask this. 3% of human beings don't have unilateral adrenal gland. So it becomes important, especially if it's what I'm saying is you are unable to appreciate on the left, but you should be able to appreciate on the right side, because if the adrenal gland is missing on the right side and you have adrenal gland on the left side and you remove it, then the patient will have trouble post-operatively.
Yes, sir.
So that 3% on the right side, let us say there is no adrenal gland, then it's a problem. So I think you can see on the right side, just the first image, there is a first image on the top. Yeah, there is some features. That's why it's better to see in the packs. You will be able to appreciate the adrenal gland. Okay. In upper tumors, sometimes you will have to remove the adrenal gland. That's why. So you should, while describing the CT, you should describe it from a surgeon's perspective, in addition to, of course, radiological terms. Plus, inhomogeneous enhancement, margins are irregular, tumor is about 6 into 5 centimeters in size, like that. Okay, right. So we'll see the report. The size is not mentioned, it's written. No, the tumor size is important. Anyhow, that report should have.
The size was not mentioned in the report, sir.
So how can you accept the report, man? It is very important because you need to decide what type of surgery you want to do.
We had a PET CT also done. There the size was mentioned, sir.
You don't need a PET CT to know the size, man.
No, sir, but because she had come with this USG and CT report.
Why did you get a PET CT? What more information you want which is not available in the contrast CT?
She seemed to have the metastasis and ulcer, so from our side, CT was done, sir, to know the status in the rest of the body, sir.
Okay, the only way you can defend is there are large lymph nodes in the hilum. You want to see whether there is any involvement of the chest, lung involvement, mediastinal lymph nodes and all those things. That's the only way you can defend. But
Yes.
usually the treatment is still here. You don't actually, in exam, if you get this case, you should not, you say chest x-ray if you want the chest CT, but don't for RCC, it is, PET CT is not the first investigation of choice.
Yes.
So just because you have a PET CT scan machine there, you should not, or because it involves a lot of extra cost to the patient and it is not going to change your management. So you go by what is recommended rather than you have do some fancy test and then end up in trouble.
Yes.
So do you think this is RCC or a TCC?
Sir, sir, it could be RCC, sir.
Why? If not, why?
Because, sir, enhancement was there in the tumor. Some enhancement was there, sir.
So you mean to say TCC does not enhance?
TCC also enhances, sir.
So,
and this is hypervascularity also.
So usually the reniform shape is maintained in a case of RCC. I don't know, that's okay. Points in favor of TCC would be, I think, a little bit less enhancement of the tumor. Second is the tumor is usually located in the PCS, in the central part of the kidney, rather than outside. And the lymph nodes are more often involved in a TCC rather than in the RCC.
Central.
Calicial details, see, you cannot comment. You cannot comment on the longitudinal sections. You should be looking at the cross sections because they may be irregular, it may be obstructed and all those things. So there may be no excretion of that contrast from that upper calyx and it will appear as if it may actually be dilated. That is actually vascular. Okay, proceed. They're done PET CT, we'll have a look, but no issues. Yeah, Priyanka, how did you change the management? Any additional findings you have got? Any more images? Finished? Priyanka, you're there?
Yes,
Hello?
sir. Yes,
Yeah,
sir.
Any additional findings in the PET CT compared to the regular CT?
No, sir, no significant additional findings. Just uptake in the lymph nodes was confirmed in the periodic nodes. It was suggestive of an RCC as per the CT, sir. Report is given, sir, in the next slide.
Next slide. So what do you want to do? Shubham.
Sir, left radical nephrectomy, sir.
Okay. So I have just a question. Now this is 7 centimeters. It is well above the level of hilum or just at the level of hilum. Why can't you do any partial?
Lymph nodes are involved, sir.
Yeah. So if there are lymph nodes and it is likely to be malignant, sometimes you can have reactive, and these lymph nodes are more than 1 centimeters, and there is involvement of the adrenal, whatever they mentioned as infiltrating, and there is extracapsular extension. There is no point in doing partial in this case, unless the patient has only, this is the solitary kidney, and you will be pushing them directly to dialysis. So only in those conditions you, not as a guideline, but sometimes you have to do to salvage the renal function. But otherwise the treatment is radical. You want to give some adjuvant treatment before, or you want to do the surgery directly? Do you want to do a biopsy in this case?
Sir, directly, sir, radical nephrectomy, sir. And stage 2,
Radical
B.
nephrectomy includes lymph node. Correct? You want to remove that lymph nodes also?
Yes, sir. Lymph node also. Lymph node dissection.
So you say the patient your surgery is over and you are done? Or?
No, sir, we'll wait for histopath.
Okay, no, what I'm saying, we all wait for histopathology, no doubt. But what I'm saying, does this surgery is the only treatment for this patient?
No, sir. After that, we'll be continuing surveillance for 5 years. Sir.
No, surveillance is done for everyone. Does this patient need additional treatment?
Sir, some immunotherapy, sir, after.
No, why I'm saying is, see, when you operate this patient, before you operate this patient, you have to say that the tumor has spread beyond the kidney. It has gone and infiltrated the adrenal, and it has gone beyond the kidney into the lymph nodes. So it is no longer locally advanced now. It is not localized, it is locally advanced. What the difference? So when it is locally advanced, you may have to give additional treatment like TKIs and all that you should tell beforehand to the patient. Because once you do the surgery, then you say still it is, you are not able to cure it. So the patient may take it that you are not done the complete job.
Yes.
See, in malignancy, the patient, the family, everybody will be anxious. But you should say in comfortable terms and in a compassionate manner what is the condition. Most of the litigations are in oncology.
Yes.
Even during COVID times also, people, when you have an oncology malignancy, you have to operate early. You cannot wait for 6 months, 3 months and all that. So oncology is something, you should be upfront and saying this is how it is. Because I would you should put it back to the patient. You had hematuria from last 2 years, you have come after 2 years. If you had come early, probably it wouldn't have been spreading beyond the kidney. Now it has become a locally advanced stage. Anyhow, that apart. So, what technical difficulties you may find during the surgery? You want to do robotic open lab?
Open, sir.
Open. Suppose, you can say, I would have done this like this, but if the person is competent, they are doing now even the IVC thrombus, they are doing below the hepatic confluence, they are doing robotically. At particular centers, at centers of excellence, they are doing. So even if you have lymph nodes like this, it is not a contraindication for lap or robotic.
Okay, sir.
7 centimeter. They will do it and then remove it. They want to do it. And they will put an incision in the lower abdomen and remove it. So we have done the surgery, are waiting for it? Okay, proceed. So what lymph nodes you are going to remove? Shubham?
Sir, perihilar, sir, and the para-aortic lymph nodes, sir. And
So in which condition you will do a proper lymphadenectomy, and which condition you will do something called berry picking?
sir, if
Yeah. If it is a urothelial tumor, then you have to go and remove the entire lymph nodes in that particular template. Whereas in RCC, you remove it mainly for histopathological confirmation so that you can plan your TKIs accordingly. Only if it is a clear cell variety or some papillary varieties, you can think of TKIs. If they come as something else, collecting duct and all those things, then the TKIs have a lesser role to play. Growth. So what is missing in this report? Did you remove the adrenal in this?
adrenal will be removed, sir. Tumor is involving the adrenal also, sir.
Is it mentioned in this or it's next slide? Okay, because if adrenal is involved, then it becomes T3A, I think. Oh, T4, okay. Urothelial carcinoma. So if it comes like this, what do you want to do?
Sir, it's high-grade urothelial carcinoma, and we have done nephrectomy already. And so, ideally, sir, for urothelial carcinoma, we should do nephroureterectomy with
Correct. So that is the point. If it comes as urothelial carcinoma, you have to go and do a nephrouretectomy and you have to do a proper lymph node dissection. Ureteric growth, there is a ureteric growth also. Of course, you will also need to do a cystoscopy in this patient. Cystoscopy.
Without any bladder.
Cystoscopy followed by the lower ureter also has to be removed. 40 years.
Family history, violent significance.
Now, if you look back after looking at the histopathology, it was less enhancing, which is one of the features of urothelial carcinoma. Anyhow, we all agreed that it was looking like RCC. Looking after seeing the histopathology, you can always change your way of thinking, but it was less enhancing, definitely. And the calyces usually are compressed in RCC, whereas they are destroyed in urothelial carcinoma. Usually we don't do frozen section. If you want to do, you should plan a biopsy prior. So what are you planning now? It will be, see, what percentage of tumors of the upper tract have involvement of the bladder?
Sir, 15 to 75%.
15 to 75.
Yes, sir.
It is, see, 3 and 30 is what I remember. 3%, when there is an involvement of the bladder, upper tract is involved in 3%. And when there is upper tract involvement, the lower tract is involved in 30%. Roughly, I'm telling, this is 3 and 30, easy to remember. So, if you have not done scopy in this case, you should do a scopy and you have to follow up with the patient because she can have a similar tumor on the opposite side or in the bladder. Now the management comes whether you want to give adjuvant chemotherapy. TCC means urothelial tumor means you have to give some chemotherapy. What chemotherapy you want to give?
Cisplatin based.
What are the regimes, man? Forgotten?
Yes, sorry, sir.
Huh?
Sir. Sir. Actually, sir, in this case, sir, just the biopsy report has come recently. So
It doesn't
we
matter.
are planning to follow the
Biopsy report comes, no issues. I'm not talking about this case. I'm talking about in general, what is the chemotherapy in a case of urothelial carcinoma? What do you give? What are the two standard regimes? MVAC and GC.
MVAC, sir.
MVAC and GC you should be able to tell minimum.
Sir, just want to permission, sir, before I just we have an early OT, sir, schedule. I would like to take leave, sir, if permitted from you, sir. Just the fact that we are following up this patient after a week or so, and then we'll be planning to do a cystoscopic evaluation, and then we'll decide the further plan of management, sir, for this patient, sir, since it cannot to be a TCP.
Of course, all the management has to be discussed with the patient. If they are willing only, you can proceed. But if the patient says, doctor, whatever is best for me, you do, go ahead, then chemotherapy is required. Of course, cystoscopy and that uretectomy has to be done with the lymphadenectomy as per the template.
Yes, sir.
And opposite kidney function to be monitored. I don't know, the creatinine would have gone up.
Okay. Okay, sir.
Okay.
So can I take your leave, sir? Thank you, sir.
Okay, thank you.
Thank you, sir.